epithelium which is covering the anterior surface of your eyeball, which is called the conjunctiva. Okay? The most common problem associated with the eye is the refractory disorders. Most of us have these refractory disorders. This is one of the major function of your eye, refraction, and the second major function is perception of the image produced by refraction. Refraction is done by means of two structures, the cornea, which is the anterior transparent membrane, and the second is the lens. Okay, so any problem with these two will result in the refractory disorder. Okay, then the problems in the lens or in the cornea or in the overall shape of the eyeball will result in the refractory disorders. Okay, they will be dealt in detail in your physiology lecture, but we will try to understand the basic anatomical concepts behind those. Okay, then there are some corneal disorders. Cornea is at the front, in front of dealing with all the infections and everything. Is always that thread, can be infected, can be inflamed. It's a proteinaceous structure, so the protein lying within them can coagulate, produce some opacities in it. If it gets inflamed or infected, the ulceration can occur, the ulceration can lead to perforation and can lead to a complete damage of the cornea also. Okay? In case of a complete damage of the cornea, when we are unable to treat it, we have no option but to replace the cornea with another cornea, which is called the corneal transplant. Okay, in order to understand these all concepts, we have to go through the basic structure of the cornea. Right? The next is the cataract. Cataract is just the opacity of the lens. Okay, nothing special in that, but the important thing is that when lens get opaque, we have to remove the lens and replace with an artificial lens. For that, we need to identify where is it exactly located, how it is held over there, so that we can take it out easily. And then the lens also do accommodation, which is the control, which is the only control on accommodation which we have. Okay, so we need to understand that too. Then there is a disease called glaucoma. Actually, if you look at your cornea, cornea is a very thin membrane. Behind the cornea, there is a space which is filled up with a fluid called aqueous humor. This aqueous humor produces a tension over there. Because of the tension, the cornea maintains its shape. Okay, this fluid is continuously secreted and continuously absorbed. So if there is an extra production of this fluid or there is decreased absorption of this fluid, this would result in increased fluid, increased tension, and that is called glaucoma. That will definitely change the shape of the cornea, change the refraction. It may produce a back pressure on the retina and can destroy the retina also. Okay, so to treat it also, we need to understand how it has been drained, how the drainage is done, and how it is produced. Okay?
Can glaucoma cause the next one, retinal detachment?
We will see it. Okay? Then comes the blindness. The patient will present with blindness. Most common cause of the blindness is the retinal detachment. To understand the retinal detachment, we will have to go a little bit back to the embryological development of the retina, how the retina is developed from two layers, and how these layers are held together, what are the forces which are keeping them together, and if those forces are gone, how this retina will detach, and how then the patient will get the blindness. Okay, so these are the areas which we have to cover today. Okay, we will be just going through the basic anatomy. Okay, this slide you have already done yesterday probably, Dr. Ramna. Okay, I will just quickly go through it. You have two lids. The ends, between the ends of the two lids is the fissure which is called the palpebral fissure. When you open this palpebral fissure, you are able to see the eyeball. The two portions of the eyeball which you can see is the whitish zone, which is called the sclera, and in the middle, the colored portion, which appear to be colored, is the cornea. But if you look at very carefully across the cornea, you would see that it is completely transparent and the structures lying behind it are producing all the colors which we see in each other's eye. Okay, so the point where the cornea and the sclera met is called the limbus. Okay, if you look into the eyes, you will see a plate-like structure with an aperture in it, which is called the pupil. This plate-like structure is the iris. This is a movable structure. It is kind of an inspector. It may be constricted, it may be dilated. Depending on that, the pupil size will narrow or will increase, which will control the light basically. Okay? Interestingly, the light goes across into the retina. Do you think that you can see the retina?
No.
Why not? If the light is going in.
We can't see through, like in the scoby, reading through the.
Yes, exactly. We need a small device which can illuminate your eyeball from inside and can enlarge the image. That's it. Ideally, it's an opening through which you can see, but inside is the complete darkness. So you have to illuminate that. So that device provides an illuminator plus a lens which just basically enlarge the image from inside. So through that, you can watch the entire retina very comfortably.
What is the name
Ophthalmoscope. Ophthalmology is your study of your eye. Ophthalmoscopy, visualization of your eye from inside. Okay? Fine. So this interior complete surface is basically lined with an epithelium called the conjunctiva. Conjunctiva basically start from the margin of your lid, then cover the undersurface of the lid, then reflect onto the eyeball, and then goes up, then reflect back onto your upper eyelid, and then ends on the margin of the eyelid. So if you reflect your eyelid down, you will be able to see that it starts from here, cover the palpebral surface, hence it is called the palpebral conjunctiva, then reflects onto the bulbar part, hence called the bulbar conjunctiva. And there is a reflection which makes a cup-like structure which is called the fornix. Alright? So what is the basic function? It's just to protect your eyeball, keep it clean so that you can see comfortably across. The frontmost layer always threatened with the infection, inflammation, allergies, so the patients usually present with these all problems. Your microbiology lectures will be more focused to the conjunctival infections because the microbiological, most infections are basically the conjunctival infection. There are little bit of infections which are related to the cornea also. Okay, before we go into the real eyeball, the same eyeball which you are continuously seeing since your childhood. There is nothing special, we will be just studying it in a little bit more detail. That's it. This purple color structure is the conjunctiva which is covering the eyeball from the interior. Otherwise, this complete eyeball is covered and enveloped in a thick, firm structure called the sclera. This sclera anteriorly is continuous as cornea. The difference between the cornea and the sclera are two basics. Number one, the cornea is basically transparent and then it's not firm. The rest of the sclera is very tough membrane, is thick, and it's opaque. Okay, the basic function of this sclera is to basically protect your eyeball from outside and give it such shape.
So the only difference that it's fed, sclera is fed, and cornea not fed.
It's a very thin membrane cornea. Okay, now Just beneath that, you can see a reddish zone. This reddish zone is filled up with the blood vessels. This is called the choroid. Anterior portion of the choroid is dilated, is called the ciliary body. Head from the ciliary body is your lens. And attached to the ciliary body anteriorly is the plate-like structure, which is called the iris, which has a pupil in it. Okay? This lens is dividing your eye into two segments. I'm using the word segments. The posterior segment and the anterior segment. The posterior segment is filled up with a jelly-like substance and pushing the retina against the choroid. So all these layers are basically these two layers, the choroid and the retina, are basically sandwiched between the tough membrane of the sclera and this vitreous body, which is a gelatinous substance, and pushing the structure outward. Okay, giving a complete spherical shape to the retina. Right? Now look at the anterior segment. This anterior segment is divided into two by means of this iris. There is a portion behind it and there is a portion ahead of it. The portion ahead of it is called the anterior chamber. The space behind is the posterior chamber. So initially we said the segment posterior and anterior, and then anterior segment we are dividing into the anterior chamber and the posterior chamber. The ciliary body is the one which produces the aqueous humor. And the aqueous humor then drains into the posterior chamber, then comes through the pupil into the anterior chamber, and then at the limbus it is absorbed. We will do it in detail and we will go ahead. Okay, now the pressure of this aqueous humor will maintain the shape of the cornea, otherwise the cornea is a very thin structure and it will not be able to maintain its shape.
So what's gonna absorb
We will do it. It's absorbed at the junction of the sclera and the cornea. At the moment only this one.
what's gonna maintain the shape of the cornea?
The aqueous humor, the pressure of the aqueous humor. Okay, let we take all the structure one by one. Here we go. The very first structure is the sclera, which is covering the eyeball completely. It's a firm structure. Thickness varies from 1 millimeter to 0.3 millimeter. It is thinnest at the points where the muscles are attached to it. Anteriorly, it continues with the cornea at the limbus. That's what we discussed all. The two major functions, it protects the eyeball and it gives attachment to the muscles. So the muscles, all the muscles, rectus muscles, and the oblique muscles, which Dr. Amna yesterday talked about, are attached to the bone and then inserted over the sclera. Right? Let's go ahead to the cornea. Cornea is only 1/6 portion of the eyeball. Anteriorly, it's a very thin membrane. The diameter is approximately 11 millimeter. When you look at the cornea, it appears to be round. It's not round actually, it's oval. Its horizontal diameter is relatively bigger than the vertical diameter. So it is lying horizontally. Okay. At the periphery, it is continuous with a sclera. It's a transparent and avascular structure. So how will it get the nutrition? The aqueous humor, which is lying behind. So the aqueous humor will not only maintain the shape of the cornea, will also supply the nourishment. Simultaneously, it will also supply the oxygen. But the major oxygen supply of the cornea is from the air through the conjunctiva. Yes. Okay. So then whatever color you see in this conjunctiva is because of the structure which are lying behind the iris. All the colors in the eyes are of iris, basically. part of the body. The highest concentration of the receptors are there. Okay, which creates the corneal reflex. So which nerve is basically supplying it? Which trigeminal? Which branch of the trigeminal? Ophthalmic. Which branch of the ophthalmic? Long ciliary. So the long ciliary nerves arrives at the limbus and then gives the branches which goes finally inward. These nerves are so fine that they do not hamper the transparency of this cornea and still supply the entire structure in full detail. Okay, then this is the highest point of the refraction. We said we have two structures for the refraction, the cornea and the lens. What is, by the way, refraction? When light moves from one medium to the other medium, at the border it reflects, it bends a little bit. So it depends on two factors. Number one, what is the density difference between the two mediums? So if the light is moving from air to the cornea, so there is a huge difference of the densities. So that's why the refraction will be maximum at this point. Beyond, you have the aqueous humor, then the difference between the aqueous humor and the lens is not that much. That's why the refraction will not be that much. Okay? The second important thing, at what angle the light is falling on. If the light is falling straight, then there will be no refraction, the light will pass straight. But if it is passing obliquely, then the refraction will be there. So if your cornea is flat, there will be no refraction. But if it is convex, there will be refraction. So as much the convexity will be, more refraction will be, and as much the difference between the two medium will be, as much the refraction will be. That's why the refraction, since the light is passing from air to the cornea, the refraction is the highest at this particular point, which accounts for 2/3 of the total refraction of the eye we do. But this refraction is not in our control. We cannot change this refraction. We cannot change the shape of cornea by ourselves, right? But if the shape of the cornea is too much deranged, we can change it surgically. That is the common surgery going on nowadays. Through laser, you change the shape of the cornea a little bit, hence result in removal of your glasses. Sir? So then you will have to reduce that, and in that case, your cornea will be lax.
But if it was too much, you'll have to remove some. And what does the extra
fluid? We will talk about it in glaucoma. Okay. Where I found? Okay. Quickly.
The aqueous humor will only give the oxygen, bring oxygen, or
No. All the nutrition, the lymphatic drainage, everything. Because it's an avascular structure, so all the nutrition supply and all the drainage will be through the aqueous humor. Okay, it's just like the cerebrospinal fluid as it is working over there. Okay, so the disorders associated with it, mostly the trauma, infections. Infection may lead to perforations, or it may even lead to the complete opacity could also be there. In case if you have to remove the cornea, what you are going to do, you will simply cut the cornea at the limbus or from the area where the opacity is, and then you will transplant another cornea over there and stitch it with it. But in that case, you are going to lose the complete innervation in that particular area, and the regrowth of the innervation is very, very slow.
So what's the use of?
You have to see.
Yeah, but you said.
If there is an opacity in front and you cannot see, so then you want to see at least.
But you say we lose the innervation.
We lose the innervation of the senses, not the retina. Retina is still there, right? So there will be a decreased corneal reflex will be there, the protection will be hampered, but at the same time, you are able to see.
Doctor, so if something gets in the eye, the person will not be bothered? Or bothered? Because there is no intervention.
Okay, fine. Why do you get irritated with something present in your eye? We are going very slow. Because the receptors are there. If you just kick the receptors out, who is going to recognize that something is there? Okay, let's go ahead. Then we talk about the layer which is just lying beneath this sclera is the choroid. Choroid is continuously anteriorly. There is a dilated structure called the ciliary body, and then there is iris. All three structures together are called the uveal tract. Okay, and their primary function is to supply the nutrition to the entire structure. The choroid is basically the vascular layer, which is sandwiched between the sclera and the cornea. It has the vessels enter from outside. They make a meshwork of the large vessels all around, and then gives off small branches which make another meshwork of the small vessels inside, and then they give another small capillaries which make another meshwork of the vessels innermost. Okay, now this innermost vascular network basically come in contact with the retina and will make the blood retinal barriers. Going ahead, the ciliary body. Now look at this. Triangular structure is the ciliary body. Apex is continuous with the choroid. At the base, posteriorly, you can see some processes going downward, which are lined by some epithelial cells, which produces the aqueous humor. At the same time, these are hanging the lens by means of the suspensory ligament. The anterior part of it is basically giving attachment to the iris. You can see two types of muscles over here. The meridional fibers, which are attached to the edge of the sclera, and the fibers, which you can see as a cut edge over here, which are basically the circular fibers and covering the entire ciliary body across. So whenever these muscles will contract, they will narrow down the entire ciliary structure. When this ciliary structure will be narrowed down, these suspensory ligaments will become lax and will allow this lens to become more global. Okay, when these ligaments will stretch, the lens will become stretched and it will become flatter. So whenever these muscles, the circular muscle will be contracting, actually your lens will become thicker and your lens will be able to see the nearby structure, and this process is called the accommodation.
Ligaments will be loose. Ligaments will be loose.
Yes, ligaments will be loose. Okay, so the main function of the ciliary body are production of the aqueous humor and accommodation. They also absorb the aqueous humor 15%. As I told you that the aqueous humor is absorbed over here. I will explain it a little bit more in detail. There are two different zones which you can see over here. This is the anterior zone, which basically covers the 85% of the absorption of the aqueous humor. The rest of the 15% of the aqueous humor is basically absorbed into the ciliary body. And since some chemicals works over here very well, that's why this area of the absorption is of clinically significant. The iris is a disc-like structure having an aperture in this middle, which is called the pupil. It consists of two types of muscles. The muscles which you can see at the cut edges are the circular muscles, which are covering the iris like this. These are called the constrictor muscles, and these constrictor or the sphincter muscles, these are supplied by the parasympathetic innervation, and whenever the parasympathetic innervation will increase, they will contract and size of the pupil will be narrowed. Similarly, there are some fibers which are arranged radially. They are called the dilators supplied by the sympathetic nervous system. Whenever they contract, they will open up the pupil and more light will go in.
What is the constrictors?
There are constrictors which are circular. There are dilator which are radially arranged. Okay, the basic function is control the light. And the other important function is the iris recognition, which is a biometric methodology. Okay, the lens, nothing big about it. It's a transparent, elastic, biconcave structure. Again, an avascular structure. So need to be bathed in aqueous humor to be supplied. Okay, attached to the ciliary body by suspensory ligament, have 1/3 of the refractory power. Total basic function is accommodation, and the basic problem related to is the opacity, which leads to cataract. And whenever the cataract occur and there is a complete opacity, we have to remove the lens. In that case, we will cut the suspensory ligament by approaching. But first we cut this nimbus, goes in through the pupil, cut the suspensory ligament, break this lens into pieces, suck it out, and then put another lens inside. Then in that particular case, we will lose the accommodation control. But the gain will be that we will be able to see. Right? Okay, now accommodation, as I tried to explain you before, that the ciliary muscles, the circular muscles of the cilia are arranged in circle around the lens. And the lens is held by means of the suspensory ligament. When these muscles contract, the space reduces, relaxing the suspensory ligament, allowing lens to get thicker. As much the lens will be thickened, as much the accommodation will occur, as much you will be able to see the near structures. Okay. Now, if you look at here carefully, whenever your ciliary body will contract, these iris are attached to it, right? So the iris will also get relaxed. When the iris will get also relaxed, so then your pupil will also narrow down. Another interesting thing happens when you move your eye from far to near. Look at my eyes. What exactly is happening?
Accommodation.
They are converging. So whenever we are accommodating the near structures, the three things are happening together. The thickening of the lens because of the contraction of the circular muscle, at the same time the narrowing of the pupil and the eye convergence. So accommodation is basically comprised of all these three phenomena: the thickening of the lens, eye convergence, and the pupillary contraction.
Please explain the part about the iris again.
The part of the iris again, very
Can I make what happens to the iris?
okay. Just look at over here, these are the circular muscles. Okay, whenever they are contracting, the entire ciliary body is contracting. Attached to it is the iris, which is hanging from the ciliary body. So when your ciliary body will constrict, your entire ciliary muscle will also relax. And at the same time, it will narrow down the pupil. Okay? The chambers, as we identified before, this is the anterior chamber which lies between the cornea and the iris. The chamber which lies between the iris and the lens is the posterior chamber. And the only communication between them is the pupil. Let me look at it in detail, this particular area. Let me see that how much time we have, and accordingly I will go into the details. We have time a little bit. Okay. So we have just tilted this image. This is the anterior side, this is the posterior side. This one is the lens. This is the sclera, the opaque part, and this is the cornea, which is the transparent part. The junction between them anteriorly is called limbus. Okay? There is a line just behind at their junction. This one. This line, better to use my hands over here. This line, which is produced by the edge of the sclera, is called the scleral spur. So this represents the line of the union of the cornea and the sclera posteriorly. Anteriorly, there is a small groove-like structure which is called the limbus. Posteriorly, same thing is represented by a line which is called the scleral spur, because it produced by the edge of the sclera. Okay? You can see that there are some perforating areas anterior to it and posterior to it. So these are the small canalicules. Right? If you go anteriorly, you will see that the posterior surface of the cornea has very smooth surface until this particular line. Beyond that, these canals start. This line is called the line of Schwabe, the Schwabe's line. Now, between the Schwabe's line and the scleral spur, there is a meshwork of the tubules called the trabecular meshwork. This is the trabecular meshwork which basically absorbs 80%, 85% of your aqueous humor. This is the main source of absorption of the aqueous humor. Aqueous humor absorbed through these canals, then fluids move to this canalicular system which you can see over here. These canals are called canal of Schlemms, and from there this drains into the veins. So there are steps in between also which you can memorize. But for your understanding, between the line of Schwabe and the scleral spur, the trabecular network is there, which is absorbing the 85% of the aqueous humor, which is draining into the canal of Schlemms and then to the veins. Then behind the scleral spur is the area which is basically produced by the attachment of the ciliary body. Right? So this area is basically of the ciliary body. And these small canalicules are basically draining the aqueous humor into the ciliary body, and then through the lymphatic system it goes to the body. It will ultimately drain into the veins. And this contributes 15%.
What's the name of
This area, since it is between the cornea and the iris, it is called the iridocorneal angle. Iridocorneal angle. So the absorption is at the iridocorneal angle. These trabecules, these small canals, are affected by the concentration of the prostaglandins. So if you give the prostaglandins, these vessels will dilate and more absorption will occur. That's why the prostaglandins are used as a treatment of the glaucoma. Okay? Understand?
Yes.
So now, these are the projections which are called the ciliary processes. They are lined by an epithelium which produces the aqueous humor. Aqueous humor will go to the posterior chamber, then passes through the pupil, then goes into the anterior chamber. In the anterior chamber, it will either goes to the trabecular meshwork, the 85%, or go to the ciliary body and absorb over it.
So it starts in the ciliary processes, not in the ciliary process.
Yes. Epithelium of the ciliary processes. So the aqueous humor is produced by the ciliary processes. Quantity is just 0.2 ml. Okay, primary source of nutrition to all the structure in this region, maintain the same shape of the anterior segment, and this represents the path of the drainage which I just explained. Okay, going ahead. Now, two things can occur. If the iridocorneal angle is obliterated because of any reason, you can neither drain the fluid into the meshwork, trabecular meshwork, neither you can drain it into the iridocorneal angle. So this will increase the pressure of the fluid inside, and this type of glaucoma will be called the closed angle glaucoma. Okay, and this we can basically examine through an examination mechanism called the slit lamp examination tool, through which we can look at behind the cornea, between the iris and the cornea, and can see the angle, whether this angle is open or not. Okay. The second thing, gone. Battery is gone. Okay. Let me use my own batteries now. Okay. Okay, fine. The other possibility is that the clavicular meshwork, the meshwork trabecules, they get blocked themselves, or they narrows down. In that case also, there will be a complete blockage, but in that case, the angle will be open, and this kind of glaucoma is called the open angle glaucoma. This glaucoma will be dealt with you in detail by Dr. Dilip when he will be dealing with the drugs affecting and treating the glaucoma. Okay. Treatment modalities will depend on either by decreasing its production or increasing its absorption.
So what do you mean by decreased angle?
Decreased angle glaucoma, as I told you, that there is an angle between the cornea and the iris.
This angle.
So all drainage pathways, both the drainage pathways are line between. If this angle is obliterated, so then this iris will be approximating the cornea and blocking this entire pathway of the drainage. This type of glaucoma is called the closed angle glaucoma. So the treatment methods will be entirely different with both of the glaucoma types. Okay, coming to the vitreous body. You must have made the jelly at home. What you do, you take a large bowl of water and put a small amount of the solvents and then cook. It's become a jelly, right? Just do one thing, take only the half the packet. The jelly consistency will be much lower. Okay, this kind of jelly concentration is the concentration of vitreous body. So it contains mainly the water, a very small amount of the solvents, proteins are there. Okay, these proteins, in a minute later. So the basic function of this jelly is to push all the material, all the retina, along with the scleral layer, so that a smooth surface can be produced. Okay, we cannot have a solid structure in between because we need to have a transparent structure so that light can easily go through. One problem with this vitreous body is that it also contains small fibrils, the collagen fibrils, which though are transparent, but if they get opaque, they will produce small floating substances in your eye field. Okay, if those are too much and bothering the vision a lot, then we have to remove the vitreous body and replace with another artificial gel over there.
So you mean that there is something that can accumulate in it that will cause?
Yes. Okay, so the basic function of this vitreous body is just to push the retina along with the sclera and produce a spherical globe inside. Okay, coming to the retina. Retina is the innermost layer. So this is the cross section of the eye, and if you note very carefully that the The optic nerve is attached to the eyeball a little medially. It is not exactly behind, right? The point where the optic nerve attached, this is the exact same point where all the retinal vessels get in and then spread out all the retina. At the same time, all the fibers generated from the retina basically merge over here and then make the optic nerve. So this area is devoid of the rod and cones, which are the primary receptors of your visual acuity. Okay, so this spot you cannot see, hence this spot is called the blind spot. And this blind spot lies a little bit medially. And if you draw a line straight from your corneal lens pupil, you will fall on a point posteriorly. This point is the point of your highest acuity because all the images will be placed over here, and this is the most sensitive point in terms of visual images. It has the highest concentration of the cones. This is the point where you produce all the images. All the peripheral part of the retina basically help in developing the peripheral image. So the basic image which is developed is at this point. This point is called the macula, and its center portion is called the fovea centralis.
What is the significance of the black spot?
The black spot is the place from where all the vessels and all the structures are basically enters. Okay, when you visualize the retina through the ophthalmoscope, you get an image like that. Okay, so if you look at that, this is the medial side, this is the lateral side, you will find a spot in the center, which is the highest point of the visual acuity, the macula, and on medial side, you will find this point where you can see all the retinal vessels are basically entering and going at a different direction. This is the point which is the optic disc, which is basically is the blind spot. Now this optic disc behind is continuous with the optic nerve, which optic nerve is continuous with your brain actually. Dura mater runs around the optic nerve until this particular level. Okay? Hence, your CSF pressure may affect this particular area if the intracranial pressure is high, which will produce edema of this optic disc, which could be visible through the ophthalmoscope, and this is called the papilledema. Okay, so at the optic disc, you can observe the papilledema. Similarly, through ophthalmoscope, you can identify the condition of these vessels which derange during because of the diabetic neuropathies, because of the hypertension, and because of the other diseases. You can also observe the retinal detachment also through the ophthalmoscopy.
Is there any relationship between the intracranial pressure and the aqueous humor?
No. Okay, now the retinal layers. Just quickly go back to the embryological development of the eyeball. You remember the eye is developed from an ectodermal cup. This ectodermal cap actually makes the retina only. The rest of the structure is basically developed by the structure surrounding it. The optic cup is comprised of two layers. The layer which is basically covering the inner side of the cup, and the layer which is covering the outer side of the cup. The layer which covers the outer side of the cup basically makes only a pigmented epithelium, and the epithelium, the layer which is inside, will make all the rest of the layers of the neurological layers basically. So in short, we can say that the outer layer will make the pigmented layer, the inner layer will make the neurological layers. Okay, the neurological layers will be further divided into many layers. Okay, now these two layers, which are this one, the pigmented layer, and this thick main retinal layer, which is the neurological layer, are held together by the physical force of the vitreous and the sclera. Though there are microvilli which basically try to hold these cones, but if the physical force is out, they will separate out. Okay, so the physical force is necessary to keep them together. Now what this epithelium is doing? This epithelium has the tight junctions. Beneath them is the choroid, and the innermost layer of the choroid is the choroid capillaries. These choroid capillaries will make, with this epithelium, the blood-retinal barrier. Okay, so all the things, all the material which is going in is controlled, governed by this pigmented epithelium, and will keep this environment under control. These rods and cones are the highly stimulated cells. Your light is continuously falling on your rods and cones. So they are depolarizing, polarizing, depolarizing, polarizing very, very rapidly. So they need to be accommodated very, very fast. And that all need a wonderful environment, and that environment is produced by this pigmented epithelium. Okay, the other important thing is that the light is coming from there. So the light will pass through all the retinal layer in order to reach to the rods and cones. It will affect the rods and cones, depolarize them, and the rest of the light is absorbed by the pigmented epithelium so that it may not reflect back and try to produce another image of the cone. So your fineness of the image will depend on that how much extra light is absorbed at the pigmented layer. So these are the function of this pigmented epithelium, absorption of the light, blood-retinal barriers, and the retinal immunity control. They also eat up the ends of the cones continuously so that the cones can continue to produce and their ends can be phagocytosed continuously. So that this is the basic mechanism how the cones, rod and cones maintain themselves. Dr. Zafar will further talk about it. Okay, the neurological layer, as we said, it's further divided into 9 layers, and that Dr. Zafar will talk about it in histology.
You mentioned the physical forces of what are holding the pigment.
Here we are. Okay, so what are the physical forces? The sclera outside, which is the tough membrane, and the vitreous body inside, which is pushing the retina against it. So now, if something happens to your vitreous body, it will shrink. If it shrinks, it will track the cornea off from the pigmented layer, right? Or if there is a trauma, your retinal layer gets ruptured, what will happen? The vitreous itself will seep into this pigmented layer. And once the fluid is there in the pigmented layer, there is no attachment actually. It will push the two layers and will make a space for itself. In that case, again, there will be detachment in the blindness. Or there may be an inflammation over there in that particular layer, an infection over there in that particular layer. In that case, the exudate will accumulate over there and it will separate the two layers. So, thank you very much.